mostly mature ones, with smudged or basketball or lymphograndular bodies in the background. I don't know if you are able to see, we have material that has remained after the lymphocytes have degenerated. And they usually, when you have them, many of them, it signifies a condition, most likely an oncological condition or cancer process happening. Now, how does this disease kill somebody like this one? If you don't identify this in early stages, then it can be develop into a bad aggressive cancer known as Richard's syndrome, whereby it transforms into an acute phase and it creates another different cancer that will kill the patient very quickly. So we have to be very consistent. Make sure that every time you see something on a slide is an indicator of a process that is going on. Now in myelodysplastic series, we have acute and chronic. And acute myeloid common in adults, but occasionally you can find them in children, child like 14 year, 12. I found even in 6-year-old child with chronic myelocytic leukemia. And it is very interesting because acute myelocytic leukemia, you will find that there are beautiful structures on the slide. The counts are usually very high on the machine. But what strikes you most, that these cells, occasionally you might not be able to differentiate them and know whether they are lymphocytes or they are granulocytes. So what helps you to identify these is you have to check at the finer details of that cell. Like you focus and check in the cytoplasm. You will find some small granules inside. And if not, you will be able to see some features, intracytoplasmic features called our rods. They are pink condensed granules that form something like an elongated structure. And that's a diagnosis for you to know that you are dealing with the acute myeloid leukemia. You won't find this in lymphocytic leukemias. So other findings that you can find a patient presenting with a skin rash like this one. We call it leukemia cutis, affecting the skin. And what happens on this one is that most of these cells proliferate in large numbers until now they come on top of the surface of the skin. This, in case you do like a fine needle aspirate on this gland, you'll find the same picture that is in blood. And this is called leukemia cutis, a simple skin condition that you can assume, and perhaps the patient will be treated for allergies, and others will be treated for fungal infection, but the real problem will be leukemia. So on the WBC count, you will find a lot of neutropenia, meaning most of the cells have not transformed. They have not differentiated into larger cells. So the machine cannot be able even to differentiate between whether they are lymphocytes or granulocytes. And then such patients can also present with clotting problems, and they can end up with disseminated intravascular coagulopathy known as DIC. In chronic myelodysplastic leukemia, mostly it's very simple. Also, the patients are asymptomatic. They walk in with complaints of malaria, chest pain, or something like that. But on physical examination, such patients have splenomegaly, and the doctors will always treat them for other things that are not this. And then the blood, usually you will find a patient who has mild anemia, or some have severe anemia based on the duration of the infection. And what will help you know that this is a leukemia process, the WBCs will be very high. I found patients with around 350,000 WBCs count on a machine, and most of our machines sometimes even are not able to run such high samples. And sometimes also on a smear, you only find leukocytosis with left shift, most of the band forms. And then also you will find neutrophils eosinophils and basophils at the same time. So for you to be sure of which type of leukemia is this, use of Philadelphia chromosome, which is positive for chronic myelocytic leukemia. Now we are done with the leukemias of the blood. We want to check on the solid organs where lymphomas can also grow. And for this one, you should understand the lymphatic tree of someone. The lymphatic tree has several locations. The way I've drawn this one, you are able to check any green dot is a form of lymphatic tree. And the lymphomas generate themselves at the site of those lymph nodes. And they could be mostly around the neck. You have lymphadenopathy at the neck, or in the armpits, or in the inguinal region. Occasionally, the hidden ones, the bad ones that are hidden are in the stomach, in the mucosa-associated tissue, mild tissues, or under Peyer's patches. You can also find a lot in the lungs, And for us, mostly the doctors will see it on X-ray and they'll suspect TB, they'll suspect other things. But remember, we have the hematological malignancies that can also present in any part. And sometimes they also settle in the spleen and they come out from there and now move in other systems of the body. So the major two types of lymphomas that we have the Hodgkin and non-Hodgkin lymphoma. In Hodgkin lymphoma, I've encountered several patients. Mostly patients come with masses, especially around the cervical region, around the neck, as you can see from this picture. And what is very special about Hodgkin lymphoma is that it originates from the B cells. And its mode of metastasis is orderly, meaning it cannot jump from one part of the neck to the other one. Mostly it follows the lymphatic tree, the way I've shown you. It will move from one gland to another one systematically. So the patient presents with a painless, non-tender, meaning it's not painful lymphadenopathy. And then also they have some systemic fever and severe pruritus. They itch. But now what's very important here is that we also need to sensitize most of our clinicians because such patients are treated for TB, and there's no TB here. Even if they have done GeneXpert and they have done sputum, there's nothing that they are going to find. But after you do a fine needle aspirate or they do a biopsy on this lymph node, they'll find that it has very special features. And what's also important in lymphomas, the cell count, especially on the machine of hemogram, the cell count is usually normal, or they could be having negligible differences to alert you that there's a problem going on. So you need to advocate for samples from the lymph node, either by fine needle aspirate or for biopsy for examination. So investigations in such patients, they need to do a full blood count. And why full blood count? And I said it doesn't manifest is because other leukemias and mononucleosis will present with the same symptoms. So you need to do a differential diagnosis by doing full hemogram. Like in leukemia, the cell count will be very high, but in lymphoma, the cell count will be normal. And also you need to do FNA for cytology, bone marrow biopsy for histology. And then from this, you are able now to continue doing your other tests like immunocytochemistry and flow cytometry to know exactly what type of infection you are dealing with. Now on the cytology issues, you will find a beautiful picture of red Sternberg cells, which is very characteristic. It's like 10 times the size of a normal small lymphocyte. So, and it has very beautiful features. Inside it has two nuclei or mirror. They look like one looking at the other one, and you won't miss it. So for non-Hodgkin lymphoma now, this one, it can arise from different types of lymphocytes, unlike the Hodgkin lymphoma. And also, they have irregular pattern of spread. It's like you find this tumor today in the one cheek, Then tomorrow you might find it somewhere else on the body surface or in the stomach. It doesn't follow any lymphatic tree metastasis. And mostly it's very common in children. In your settings, you'll always find them. Such patients are having hematological conditions. And sometimes also, these swellings are very non-tender, meaning that they don't have any pain. But when you touch, they are very hard masses. So if the patient presents with the fever, rash, abdominal pain, with hepatosplenomegaly, the way you have seen these patients here on the diagrams. Sometimes others present with masses in the testicular region, the gastrointestinal, and also in the same happens in patients who have other comorbidities like for acquired HHVs, the human virus that causes sarcoma. We have the Epstein-Barr viruses that causes Burkitt's lymphoma. We have even H. pylori infection that causes mucosa-associated lymphoid tissue lymphomas. So, such clients, you do FNA, you do a biopsy, you will find classic cells. The ones I've put here, the micrograph here, very beautiful but bad large cells, darkly staining with evacuations in their cytoplasm. Very characteristic, you won't move it. So compare this small lymphocyte with this abnormal lymphocyte that has cancer, they don't match. So we should learn to check on smears. We should learn to check on even if you have not trained as a cytologist, you should learn to check on smears. You can build your own skills slowly by slowly using mentors, and you go far. So such patients, the end report we recommend usually for cytology, histology, then you do immunocytochemistry, then you also do flow cytometry, you'll find the problem of such clients. Another condition involving this, we have multiple myeloma that affects the plasma cells. I said during the hematological hemopoiesis, we found where plasma cells are coming in. They are part of the B lymphocytes. But because of the cancer processes, they can do many things. Like a patient coming with pains in the bones. Sometimes some come with recurrent infections, others come with hyperviscosity. Hyperviscosity is whereby your blood is very concentrated. It's like you do recurrent renal diseases and hyperglycemia, whereby you are doing like a UEC and you find a patient has what you should be conscious to find out what's happening. You will find that this patient has myeloma because the myeloma cells produce a lot of toxins that eat up the bones, such that now the whole of the PPF, you'll find plasma cells. You should be able to identify a plasma cell on a PPF. And the cells that are forming a lot of Rulex formation, as you can see here. That should give you an indicator of this with some anemia that's not classified. Then you should be able to recommend for myeloma screen if you can do urine dipstick to look for the abnormal proteins. We call them Benz-Jones proteins. And you can also do UECs. I said you'll find out of calcium levels. You check on urate, you'll find it's very high. Albumin will have issues, calcium, phosphates, all of those, the bone chemistry issues will be very high. Then you can also recommend for urine electrophoresis and also serum IgG. Then on the bone marrow cytology, mostly or histology, you'll only find pure myeloma cells in circulation. And then on the electrophoretic pattern, you will find out of gamma proteins, very high levels of gamma proteins, as you can see from this picture. Then this is just a demonstration on On the bone marrow, they take a bone marrow spread, they make smears, then on the microscope, you only see good pictures. Another condition is the myeloproliferative syndrome. When we say myeloproliferative, we are saying myelo means the myelocytes. Proliferative means they are proliferating at a very high rate. Then syndrome is a combination of many things, bad ones, syndrome cells in the bone marrow. So in this one, mostly what we are aware of is but anytime you do a hemogram and you find a patient having the packed cell volume is about 50%, then you should be conscious. The patient
Yeah, we are proceeding. We are proceeding well. I can see your questions and your remarks. And I just want to say that you can continue writing your questions and your remarks on the chat box. And you can be more specific so that your question can go to the panelists. And then, as I'd said earlier, we shall be able to bring in all the questions and remarks at the end of the presentation. And for those who are asking for materials for this particular presentation, it's available on YouTube. So you can go to our YouTube and you can be able to just look for Lab Medicine Society of Kenya. I've shared the link on the chat box, and that's where you can get reference to this presentation. Otherwise, welcome, Evelyn.
Yes, thank you, sir. So we were on myeloproliferative syndrome, and I said that the most common thing that we find here is polycythemia. I said something on packed cell volume, which is an indicator of a lot of blood system. The cells, the red cells are very high. Occasionally, for this one, you'll find that the problem is affecting all the myelocytic series cells, the red cells, the platelets, and also the white cells. What is the criteria for you saying that this could be polycythemia vera? One, they will have an elevated hemoglobin level, HB of 20, 18, above the normal HB levels of an individual based on gender and age. You will find that you have elevated hematocrit level, the packed cell volume above 50, you should be conscious about that. Again, also you have a lot of increased red cell mass. Like occasionally when you want even to do a PPF, you want to make a PPF, you spread the smear, but it can't move. It makes a very short smear, which is very dark. That's already an indicator. And if you happen to do ESR, you'll find it is at 0, it can't move. That is an indicator for polycythemia rubra vera, and it's an indicator also of some myeloproliferative syndrome in the bone marrow. Occasionally, we find a lot of issues with you get a platelet count of over 1,000, platelet count of 1,000. Then you also get somebody with primary myofibrosis, whereby the bone marrow, that tissue scar, like it's a scar, it forms scars, and then it leads to the overproduction of myeloid cells. And this condition, if not like managed well, it transforms into chronic myelocytic leukemia. And sometimes it also brings something like chronic neutrophilic leukemia, eosinophilic leukemia, and others we call myeloproliferative neoplasms unclassified, meaning there are many syndromes associated with this. Such patients will present with the, as I said, with pressure. You check their pressure is very high because of the volume of blood in their blood vessels. The some will come with stroke because most of the small tiny vessels in the brain will burst because of the volume. Others will come with deep venous thrombosis because if the blood is not moving, it's having stasis with a lot of platelets and red cells. chances of forming clots are very high. So don't just see patients as patients. Always have time to listen to such plans. And on PPF, you find unclassified patterns. You don't know whether it's their neutrophils, their lymphocytes, everything is high. Then you have to know that you are dealing with something like that. Then we have this one that is we call myelodysplasia, MDS. And this one is missed out by many people, even consultants, because of how it presents. It's a group of disorders characterized by abnormal development and function of blood vessels, blood cells in the blood, in the bone marrow, meaning abnormal development. When you have something that has an abnormal development, either the nucleus is very large or there are no nuclear lobes. Sometimes you miss even granules, or the size of the end of that cell is very big. So it's associated with the bone marrow abnormalities, and it can come about due to many things. It could be genetical. It could also come out from patients who have used some cancer treatments. It develops as another secondary condition in that patient. So on the laboratory diagnostics, you'll find that these patients have cytogenic abnormalities, either in the chromosome structure, in deletion, or in extra pieces that have been added on the chromosome of ability. So the risk of progression, this one can end up becoming acute myeloid leukemia if not well identified. So how do you discover this? It is very easy. You just check on the PPF. You'll find very funny things in terms of in red blood count or blood cell on the screen. We call it erythropoiesis. Dys means bad. Erythro means red cells. Poiesis means formation. You'll find that these cells have different styles. We have microcytes, you have macrocytes, we have round ones, we have oval ones, we have teardrops. They don't have a specific diagnosis. You have to be conscious about this. This is not sickle cell, it's not iron deficiency, it is a dimorphic picture. And also, you'll find on white blood cells very beautiful structures, like a neutrophil that looks like a spectacle, like these ones. They don't have, like this, they don't have nuclear lobes. They just form like stub forms, and that's all. That cell shows that it's not mature. Occasionally, you find the cell without any nuclear joiner, like each is just separate on each other. And sometimes they don't even have granulations. Anytime you see such things on the microscope, like this, and these are the mature cells, then know that you could be dealing with the myelodysplastic syndrome. And you'll find a platelet that is very large, a platelet, but it has no granules. It's just an amorphous thing that looks like either the debris or something like that. Then also the platelet count would be very low. So what are the tests that we can empower our facilities to make sure that we arrest these cancers of blood in our facilities and from our patients? One, we need to ensure that a patient should be done a full blood count. They do a peripheral blood smear. Basic, you don't need the machines, you don't need big things here. And you are going to measure the red cells, the white cells, and the platelets. This will help you detect anemia, check on leukocytosis, thrombocytopenia. You are able to see. You are able to see whether these cells are either blasts or mature. And if they are mature, which type? If they are blasts, what are they? So it's the first clue in diagnosing blood cancer. And also, it identifies abnormal cell shapes and immature cells. Immature cells, blast, bromyelocytes, myelocytes, meta, all those are immature cells. So in bone marrow examinations, which mostly is done by pathologists, but they can only do that after you recommend. If you don't see whatever I've said, then you might never recommend for a bone marrow examination. So what happens? Mostly, you can take a bone marrow liquid sample in an EDTA bottle, or they are using the go biopsies where they are picking part of the bone tissue. It helps confirm diagnosis and also assesses the severity of the condition. Like this is a bone marrow aspirate, whereby in normal circumstances, a normal bone marrow has different types of cells in a certain population and percentage. But you find that in this bone marrow, everything is the same, like it is uniform. All are plasma cells. This is already a sign of malignancy. Then on this one, we have very big cells, as you can see, with a lot of cytoplasmic vacuolations. This already, even if you have never done cytology or pathology, you will see them and you know there is something happening here. Flow cytometry, some of our facilities that are next to us, referral facilities, you might not own the machines, all of them, but you have a facility next to you that can do flow cytometry in most of these referral and research centers. We should be able to recommend our patients for such procedures. Like after you do a PPF, then you see the abnormal things. Kindly at the comment side, this patient, you can make a comment that this patient is indicated for bone marrow aspirate cytology, bone marrow aspirate for cytogenetics, or bone marrow for flow cytometry. And you are going to save that patient immediately. They are going to heal because cancer is treatable. But anytime you just sit and leave that sample to go without a PPF, without any recommendation, that patient, you have left that patient to go and die slowly in their homes. So what is the flow cytometry? Today I'm just going to mention, but we can prepare some other sites we talk on real things. Like under flow cytometry, this one detects and measures the physical and chemical characteristics of population of cells or particles in terms of their sizes, their shape, their surface antigens, granulation. So what happens here is like you have seen something that's not matching, then you recommend, so that you want to know exactly what it is. You recommend for flow cytometry. What type of samples do you take? It's just blood, bone marrow, or other tissues. So there are special programs on how to do this, but today is just a mentorship training, I'm hoping so. So the cells are stained with the light sensitive dye, that's a fluorescent dye, and they are placed in a fluid and then passed one at a time through a beam of light, the way I've seen here. So these cells come through this pipe. I don't know if you're able to see. They come, this is the source of the sample. So they pass here, and from here we have an opening where there's a beam of light coming through this. So as they pass, each is identified based on the size, the granulation, the surface markers, such that they disperse a certain beam of light like this one. They emit something that is measurable on a computer, then they form patterns like this. And each location here is marked for some marker or some type of cells. From here, I'm hoping you are going to learn about it. So you have to use unfixed tissue or fluid, and also it measures size, granularity, the way I've said. But now, how do you get you are going to ask me the bone marrow. Anytime you get a bone marrow or a spleen or whatever, you want to make sure that it's going for flow cytometry. It has to be unfixed. And also, you can grind part of the bone, part of the tissue, make a solution, and send for flow cytometry analysis. So the major function for this one is usually it is used for immunotyping, for leukemia and lymphoma. Immunotyping, you want to understand the surface antigens or whatever characteristics the cell has so that the patient can benefit from treatment. And also, it can do cell cycle analysis for chromosomal abnormalities. And now this one comes in handy when you want to do personalized medicine, because each individual has different chromosomal arrangements and abnormalities. As we will see later how it works, just stay tuned and see. So cytogenetics molecular testing is another beautiful test that is used to study chromosomes and genomic structure, functions, and variations, and their role in human disease and hereditary conditions. Cytogenetics. It meaning it detects chromosomal abnormalities. How? Like you want to check on translocations, deletions, and duplications. Any of this happening to one's chromosome, they develop a condition based on which type of process has taken place. So it helps us identify specific cancer subtypes. Because as I said earlier, cancer is treated based on exactly what type of cancer is. Every marker has its own treatment. You don't just expose patients or treatment for cancer like you are doing a broad spectrum antibiotic. Each is treated based on type and subtype. So it helps us even in determining prognosis and guiding treatment decisions. Prognosis is you want to see this patient is today here. For how long is he going to survive based on whatever we have seen in his system? It shows either you are improving, that's a good prognosis, or you are deteriorating, that's a bad prognosis. And it also helps you have to choose which treatment decisions are you picking. For example, now, in identification of chromosomal abnormalities, I'm picking on the commonest one. You want to make sure that this patient has chronic myelocytic leukemia and you have got the patient. So what happens? We'll check for Philadelphia chromosome where there is translocation, and also you will find that this patient has a lot of issues with their either long arm or short arm chromosomal morphology. And I've just indicated here, like on chromosome 9 and 22, you will find that there's translocation of something. Also, it can help us identify patients who have like acute myelocytic leukemia, where when we do cytogenetic analysis, I've indicated here where on the chromosome where the problem is. And also it will help us show us the deletion of some chromosomal parts in chronic lymphocytic leukemia. So for us to understand this, we need to be very specific. First, you cannot request for a test if you don't know what you are requesting for. I'm only encouraging lab scientists to be aggressive in terms of knowing the current technologies that are on the market and also knowing what to refer and how do you refer. You see, don't just refer a patient to a facility without a written document. Two, our doctors, our clinicians don't know these things that I'm talking. This is advanced testing. We need to be focused and learn exactly what do we have on our market so that we can advise our clinicians in ward rounds, in meetings, whatever, any opportunity you get to interact with the doctor, a nurse, or whoever, always give them something good from the laboratory and we are going to move. So in terms of techniques and the prognostic implications, one, when you check on conventional karyotyping, that's mostly in fish, fluorescent in situ hybridization, there are highly sensitive techniques for detecting specific abnormalities on our chromosomes and on our cells. And also, we can have genomic hybridization and microarrays. They also detect gains and losses of chromosome segments at high resolution. Like after you have checked for cancer, it's not very clear, either in a bone marrow or in cytology or whatever. We can still refer these plants for this and you'll find that they have some genetic issues and they are going to benefit from the medications that is available. We also have new techniques like the next generation sequencing. This mostly is on PCR and other machines. It can detect complex structural variations and gene fusions with much finer details, meaning the patient can benefit from this. And whoever is dying because of hematological malignancy should not die any further because now we understand what we can do about them. So in targeted therapy, we want to choose our medicine based on our genomic, our gene structure and other things. One, most of these tests are going to help us do that. How? Because we understand our genome and what is lacking. So this is a type of cancer treatment that targets the proteins that control how cancer cells. You want to fight your enemy. So you have to have a technique of fighting them. So this technique, it targets the proteins that control how cancer cells grow. Like if they are proliferating, you go against that by introducing a drug that is going to stop that proliferation. And I didn't mention somewhere about we have markers. I think I'll mention them somewhere. Let's continue first. So it focuses on genetic changes or mutations that turn healthy cells into cancer cells. They want to check on the genetic changes. Then once the doctor understands the genetic mutation challenging the healthy cell into a cancer, they identify specific parts of the cancer cell to target for treatment. Meaning, they can decide that they want to deal with the nucleus of the cancer cell, or the cytoplasm, or the cell membrane, or the DNA material of that cancer cell. So there are many in like acute myelocytic leukemia. When you do cytogenetics and you find there's normal cytogenesis, meaning there are no alterations of the genes, it implies the patient has good prognosis. And now you can be able to understand what type of medication you are giving. So in other like acute promyelocytic leukemia, when you find that there's a translocation on 15 and 17 chromosomal areas, then you know it could be a bit favorable because there are intervention. But sometimes if you do and find that there is a deletion, like in chronic lymphocytic leukemia, deletion of 17p, that shows there is poor prognosis, and that's how now patients die, because if a doctor gives up on you because you are not going to respond on any medication, then it gives them a way to initiate other treatments that might not benefit you. So an example of the cancer treatment that they give patients, I have interacted with many and I know them, like imatinib and other thyroid kinase inhibitors for chronic myelocytic leukemia. They choose this drug based on cytogenetic analysis. And then also we have others. So targeted therapies, as you can see from this diagram, acts in many ways. There's some that targets only, they prevent or they block cell growth. Others will cut off blood flow to the tumor. And for your information, where there is cancer, there's a lot of proliferation of blood vessels around the tumor, because I think the tumor likes where there's enough blood so that it can grow very fast. So some of the drugs that they give after they have done cytogenetics, they find drugs that can cut off the supply of blood to the tumor. Some target defects in the cancer cells. The cancer cell is very abnormal in terms of size, shape, and function. Then others can also target, like they carry drugs to a tumor. You inject some drug to a normal cell that is able to circulate and find cancer cells, and now that's how the patient is going to benefit, and others. And for your information also, this one can be very interesting. Some of the targeted therapies cause cell death. In cancer things, most of the cells don't die because of some alteration in cell, the gene that prevents apoptosis. So if you have some drug that you have found that is going to stop that cell death or cause cells to die, then you are going to stop the cancer process. So this is just a picture on how the Philadelphia chromosome is shown, or how it comes about when someone has chronic myelocytic leukemia. So in your textbooks, I'm assuming you are going to read. In myelocytic leukemia chronic, you'll find that there is translocation of our chromosome 9 here under the long arm and chromosome 22. Such that when there is some translocation between these chromosomes 9 and 22, they are going to bring a cancer in our system. And there are many, we are going to read about them. So immunohistochemistry is another common procedure that is done in most of our facilities. And this one is the very simple one. You use antibodies to detect specific antigens on the cell. Simple. What happens? It can be done by using tissue sections, slides embedded on slides you take a lymph node, make a biopsy, then stain and get that. Then you do immunohistochemistry staining using specific antibodies. And now this will stain based on the presence or absence of the cancer that you are looking for. So for whoever has never seen an immunohistochemistry slide, this is how they look like. Mostly we have specific type of markers for each. If you are suspecting lymphoma or you are suspecting lymphoid tissue, we are going to use specific antibodies like CD markers. We have CD3, CD20, CD138. We have myeloproliferative. We also have common leukocyte antigens for all the white cells. So you use different types to stain on a slide, then you read the end product. And it will be very beautiful pattern. We have those that stain the nucleus alone. We have those that stain the cytoplasm. We have others that only stain the cell membrane. And ideally, you should go home and read about this because it's a long story. So the tissue samples are fixed in formalin. They are embedded just using paraffin wax. Then they make thin sections. Then you do the process of immunohistochemistry and you read. It's a beautiful procedure which can make you happy after you see it. So what is the role of the laboratory officer in all that you have said? What is your role as a lab officer? 1, pre-analytical phase. You have to ensure that there is proper sample reception and accessioning, and also collection. So you need to verify the patient identity at the reception, log in specimens accordingly, which type of specimen. It could be blood, bone marrow, it could be a lymph node, it could be whatever you find in a laboratory information system or in a register. Then you have to learn how to prepare sample preparation. You prepare peripheral blood and bone marrow smears for microscopy in terms of good staining and fixation. And also you need to, the same sample can be used for many tests for differential diagnosis, because some of the diseases are like, they look like each other. TB can mimic cancer, can mimic fungal. So you aliquot these and send them for specialized treatment based on the request. You can do flow cytometry, cytogenetics, molecular analysis. You also ensure quality checks in terms of volume, how you preserve them using the proper anticoagulant and sample integrity. You avoid hemolysis and clotting. You also reject if there is need, if there is the specimens are not meeting the criteria. In analytical, in routine hematology, you have to know how to perform and review blood count on automated hemolyzers. Like most of us have seen, they don't even want to see what the machine has produced. You will always have an issue if you don't know how to check on whether the cells are high or low. If a machine gives you a count of 300,000, you should be able to go and sit on the microscope and confirm. Is it true or there are issues with the machine? And others even don't even review those. Once the machine is done, they send that report to the clinician directly. How will this patient benefit if he has cancer? So in routine hematology, you have to review. You have to create and stain blood and marrow smears on the slides. And stain with simple things, even the diff quick. Field stain can stain. You can use the GIMSAs, the Leishman stain. And then you have to be able to identify even a blast on the microscope. Then for flow cytometry, assuming most of you who are listening are also doing advanced techniques, You prepare cell suspensions, titrate antibodies accordingly. Then you also run flow channels, panels, and also classify blasts and lymphoid populations. So in fish and cytogenetics, you are able to set up all this that's requested. So you have also to understand the internal quality materials and participate in external proficiency testing. For us in the government sector, I don't know what happens with the private sector, because sometimes there are issues with the finances, and even the administration could not be knowing the importance of such things. So in post-analytical phases, you have to learn to review and validate your results and machines that you are using. So correlate automated counts, the smear, morphology, immunotyping, and cytogenetic. You have to correlate them. You see whether they are marrying each other. You also need to have a draft in the graded report that summarizes morphology, immunotyping if there is, and molecular testing. So in terms of clinical team, I'm assuming that you are meeting the doctors and other people. You are able to discuss unexpected or complex results with the hematologists and oncologists. Also, you should be able also to understand something called critical values. Like you find something like acute lymphocytic leukemia, that is very aggressive. If you don't catch up quickly, the patient will die. So you have to provide guidance on additional tests. You have to have some knowledge to say that this patient has this, let's order for bone marrow aspirate, or we refer this patient for a further checkup. Now, in terms of laboratory management and compliance, make sure your equipment is fully maintained in terms of calibrations, because these are sensitive things. You have to do preventive maintenance in terms of log preventiveness, like preventive measures, like cleaning, like many things. And then also in terms of reagents and inventory control, you have to have enough good reagents, do quick QC on it, and also monitor expiry dates. And then also observe safety in terms of PPE. You have to check on spills and also check on other things in terms of accreditation standards. And always have to mentor major junior staffs. The way I'm mentoring you now, students in hematology, cytogenetic studies, molecular techniques, conduct competence assessment where necessary. So why is this very special? Why this topic? Is it of any need? Why this? One, a skilled laboratory officer ensures that every step from drawing blood to delivering a diagnostic report is performed with precision and reliability. You don't need just to work because you are on duty. Two, the work of that officer also is good because it gives diagnostic accuracy due to correct sample types and classification guidelines for targeted therapies. Also, when you do simple things like running a hemogram report and giving preliminary diagnosis, it improves the turnaround time of that client stay in the hospital, because rapid results can be life-saving in aggressive leukemias. And finally, quality and safety. When you have good mechanisms to do quality control, it will prevent misdiagnosis and ensures patient safety. Conclusion of our topic today: hematology relies on advanced lab testing. I hope it is true. It's not just a normal full blood count and you say the patient has been given reports. It really relies on advanced lab testing in terms of skills and machinery. Two, early diagnostic and detection and also proper classification of the diseases are very key, because you can never be treated without knowing your exact problem. Number three, auxiliary testing enhances precision and treatment planning. I hope it is true. Then, lastly, by bridging advanced lab technologies with the clinical decision making, the lab officer is a vital contributor to the multidisciplinary care of patients with hematological malignancies. If you are only fixed on the microscope, you don't meet with clinical officers, with the physicians, pathologists, others, just know that you are not a key contributor because most of them will only use your report to manage a patient. And if that report is shallow, then the patient is going to die because of your isolation. So as lab officers, we need to sit together with others that handle a patient. We have multidisciplinary discussions, we have tumor boards, we have discussions about our patients, and the end product is that no patient is going to die in our hands. So thank you for that, and that's what I prepared for this day. Thank you. Back to you.
Thank you, Dr. It was very wonderful and excellently executed. We have a couple of questions, a couple of concerns, but overall, very, very wonderful presentation. I may not be able to read all the comments from all the participants, all the 3,000 plus participants, but I shall be able to just pick in a few, and then maybe you can react to them. So maybe I'll start from Paul Lokwami. Can urine dipstick detect gamma globulin in case of multiple myeloma? And then I can add this from Sheila Chepto. If one is diagnosed of TB and treated for it and have lymphoma, can the symptom disappear after a while? Maybe you can start with those two.
Okay, thank you, Paul, for your good question. In urine dipstick, what the stick will show, it will show proteinuria. That strip will show proteins. And when you see proteins in the urine, that's just an indicator that there's a problem. So as a scientist, don't just give out. We are used to writing something, a comment at the back of the end of the report that kindly you can say, well, they do a kidney function on this client. Always, you find proteins in urine, ask for kidney function because kidneys are high molecular weight substance that cannot pass through the filtration process. So that's part of the recommendation I'm saying. And from my discussion, we say that for multiple myeloma, the patients will present with the kidney failure almost always. So that is part of a recommendation. And once you do a kidney profile, you'll find that some of the things are either very high or very low. And that's the start point of that patient's healing. And then for Sheila, a patient with TB, I'm assuming the patient had lymphadenopathy. But remember, most of our clinicians, when they see a patient with lymphadenopathy, they just go straight to anti-TB treatment, even if gene expert is negative. I've encountered millions of those every day. We quarrel with them. So before we say that the symptoms didn't disappear, at the initial stage, was there TB? Was it confirmed laboratory? Did the laboratory do any testing on that patient? If not, then they were given false medication. But if it was true, then you can have two things at the same time, even three. I find patients with fungal, with TB, and with cancer at the same time. So for you to help that client, you need to do a comprehensive check. And that's why I said, if you are given a lymph node fluid, like pus, aspirate from the lymph node, don't just go in for culture and leave the rest. Do culture, do TB, and if there's a cytologist on the site, or you can make a smear. Make a smear and just stain like a PPF and have a look in whatever you see, you'll find very strange things. And that's how you start solving the problem. So it has to be confirmed TB. If not, then the patient was given a wrong diagnosis.
Thank you for that. Evan Sokapesi, what are the specific oncomarkers for hematological cancers? And then from Jackton Oloko, what are the I think he wants to say, what are the mirror cells and where do they originate? Maybe you can answer those two.
Okay, oncological markers are very different. I've said something on different terms. I've talked of leukemia, lymphomas, I've talked of myelodysplasia, and others. Each has its own specific marker. Like for multiple myeloma, we do mostly CD38 is for multiple myeloma. If it's positive, then you are sure. The common they have, like for myelocytic leukemias. Myelocytic leukemias have different types. Which one? Is it acute, chronic? Each has its own marker. We have the T cell, T3, we have D20, like for Hodgkin's lymphoma, I think it is CD20. So you don't need to cram because there are like 101 markers for each, very specific for every tumor that you have found. So I only encourage you to just go on the site and Google. You are going to read good things about that. And then the other one was about, what was the other one? I didn't capture the other question.
Mirror cells. Where do they originate?
Mirror cells, yes. I talked those ones on acute lymphocytic leukemia. And that one is usually fine. It's just the normal lymphocytes. But now there are blasts. Blasts in which form? The blast cells over multiply in the bone marrow until they come into the circulating blood. So they originate from the bones. That's how the cancer is manifesting. There's overproduction of the blast cells inside the bone marrow, and then they escape into the circulation. That's why now after we take a peripheral sample, we make a film, we find them inside. They are originating directly from the bone marrow due to uncontrolled cell growth because of either chromosomal abnormalities or others associated with the genetic makeup of an individual.
Thank you. So very many comments from you guys. Odhiambo Cliff Randa saying this is current. The board needs to have a total change on the lab profile. Very, very many comments. And then let me just read this. And from Patrick Kaume. Can someone with polycythemia vera, HB level of 20 grams per microliter, I think he wants to say above, be allowed to donate blood?
Okay, polycythemia. Okay, sorry. Polycythemia is part of the issues, myeloproliferative disorder. It's a disorder. This is a patient who needs assistance. So in terms of clinical management of such patients, one of the requirements is that they have to donate at least a pint or a pint after some few days so that they can regulate the volume and also the cellular, like the amount of cells they have in the system because of the pressure effect I talked about. So these are patients. A patient, we only know that patients having infectious agents like HIV, VDRL, the syphilis don't donate. But in terms of hematology, this is a client who is sick. Remember, I talked about a syndrome, meaning the cells are coming out because of an improper mechanism of cell division. So that is not safe for a client. You know, you donate just like any person, but you will discard that sample because it's not suitable for use.
Thank you. I'll read another one. This must be from Cornelius Masila. What is the common hematological stain for cytological staining procedures? And then maybe I can add another one from Faith Chania. Can one inherit lymphoma? You can answer those two.
Okay, the common stains in hematology, cytology, mostly for for blood and lymph nodes, we employ Romanowski stains. The most common one is GIMSA, or sometimes we combine GIMSA with something else, like we combine GIMSA with Grunwald, or we can even use DIFQuick. DIFQuick in cytology is just the field stain, but now you are doing the reverse staining, meaning you fix your sample, then you start from field stain B, water, then field stain A, water, and that's it. This gives very beautiful, very beautiful staining characteristics for anything on a lymphoid tissue or from blood. So just, if you can get a DIFQuick or a field stain, beautiful for your hematology department. If you can get GIMSA and Grunwald mixed, not mixed, but you stain differently, a very beautiful one. But why field stain is good? Because it has no issues with pH, with the, like, you don't need to have something like a buffer solution. You only need the stain and water and something that can fix your film. But what happens with the GIMSA, Grunwald, Leishman occasionally is because of the buffer system. If you don't have a good pH to check at your samples, then it gives very poor staining characteristics. And for sure, if you want to be happy with the stains, have a beautiful fixed and stained smear. You are going to report everything, including the inclusions. You are going to see the our roads have said. Now for the other one that we are talking about, the other one was about, kindly remind me on that. On the other one was about what? What was the question from Mary?
Whether it can be inherited, the lymphoma.
Okay, lymphomas. Some of the lymphomas are virally induced. I remember I talked something on human herpes virus. I talked something on HIV. I talked on the, most of them are virally induced. Others, after you do cytogenetics, you will find that there are chromosomal abnormalities which could have come from the parents or genetic makeup of an individual. But mostly lymphomas are virally induced. And I also talked of H. pylori, a beautiful one that induces out of mild lymphomas, the mucosa-associated tissues in the stomach. So it's good to, if we will have like good and availability of these machines in our vicinity, then we can go for checkup, just to check whether you have such things in your system, because you only need to take blood and they run it and they'll find either you have some genetic makeup that can subject you to the development of these lymphomas. Thank you.
Maybe I can read this from Naomi Watman. What are the diagnostic approaches for a patient who present with both pancytopenia and splenomegaly?
Pancytopenia. So such a patient could have a differential diagnosis of many things. Pancytopenia with splenomegaly. The first thing to do, you have to think about infectious agents, like what causes splenomegaly and chronic pancytopenia. Like Kala-Azar could be one of the culprit. You have to think about Kala-Azar. You have also to think about the syndrome I talked about. I talked about the myelodysplasia, whereby all the cell lines are low and the cells that you are seeing there are not okay. They have structural abnormalities. So in this case, this patient, the basic thing to start with is the hemogram, the way you have said. And the hemogram will direct you somewhere. I use that one as my opening door. I check inside the room and find something hidden. You have to do a PPF. In chronic pancytopenia, bone marrow is part of the tests, bone marrow aspirate. And from that, you can get so many good things on the bone marrow aspirate. You can get myelofibrosis, where the scarring of the tissues. You can get something like a plastic anemia in the same context. You can get myelodysplasia, the way I've said. You can get even infections. Sometimes we have infections of the bone marrow. And if they are chronic, you won't find any leukocytosis. Chronic things just remain like that because the body now assumes the enemy is their own, then they don't react. Then you just find normal cell count or very little. And also you have to check on diet of this patient. A patient with megaloblastic anemia chronic, you will find pancytopenia and many other things. So with the help of the doctors, like request, you can think of hemogram, you can think of bone marrow spread. Let the pathologist review the slide, they'll give you a direction. You can also do a screen on infectious agents. If you can be able to send that sample to a facility that is running PCR, they might find something in that. And the story continues. So you start from somewhere as you advise others to follow on what you are thinking of. Thank you.
A lot of questions, a lot of comments, but we need to end this. But let me just read this from Abdi Abdo. What are the early laboratory indicators of throat cancer? It is common here in Mandera, but we only detect it late. Okay.
Okay, so an indicator of throat cancer, the first thing the patient will say, they are having symptoms of sore throat. Very easy. Symptoms of sore throat, meaning when they swallow anything solid, they'll have some pain, mostly solid. So they continue reducing their intake of solid diet, like if they were eating ugali or bread, they start taking porridge, and then they end up not even swallowing porridge, then they start taking milk, and it goes like that. Another symptom for throat cancer is change of voice. Like you can be talking the way I'm talking, then after some while, I can now when I talk, I produce like 2 to 3 sounds, which is not, it's not a refined sound. Like you talk and it comes out like 2 to 3 sounds at the same time. Occasionally, those that I've seen, some have some, I said, of pain, then voice change. Then I'm talking about also on a mass. You can see a mass, loss of weight, very common, loss of weight, because the diet is part of the issue. They are not eating well. And then also some will have a mass. A mass can come out any place. The throat has from the neck, where the neck ends up to where there is the salivary glands up. It's a long, there's a tube around there. So I said change of voice. Sometimes some could just lose voice if the tumor is located on the voice box. And the story continues. But now on examination, you might find a mass on the sides, or you can even find it on already it has gone metastasis to the salivary glands or in the oral cavity, or you check and you see the patient is coughing and there's nothing, because that tumor exerts pressure on different vital organs around the throat. So somebody's coughing, some are vomiting, and the story continues. So they are varied, but anytime you find somebody with sore throat, don't take it lightly, because there could be something growing at the next site.
Maybe I can just read the last one because there are so many comments. Seems these are a great area of interest. Vincent Nyabuto, are blood cancers transmitted through blood transfusion from unknown persons with the same? You can answer that.
So blood cancer mostly, the problem is not in the blood. The problem is in the bone marrow. And once the cell comes out, like it comes out, it's going to die with some time. So the problem usually is inside the bone marrow. I said about the origination of the blood cancers. I told you about the bone marrow and the lymphatic system. So blood is just an end product that will just get out. And for your information, your real body cell itself can now even destroy those cells that are not functioning, like blood cancer, whatever, like leukemias. If you are to be transfused by somebody who has leukemia, it might not have any effect because the problem is not in the blood. The problem is somewhere hidden. And that's why we are saying, if you want to be treated, they have to find the cause and the source. Where is it coming from? Just like any other cancer. If I find like cancer in a lymph node, it tells me if it is a metastasis or it is originating from the liver or from the spleen. So the problem is in the spleen, not in the blood. Treatment starts from the source, where it has come from. And that's why we differentiate these cells by doing cytogenetics. We do like the immunocytochemistry to identify where the cell has come from. Then that is where the treatment starts. So you should not be worried about blood transfusion. And you can imagine a patient who is very sick, cannot donate blood. Where will you get that blood to be given? It won't make any sense. Yeah.
Thank you. Thank you. There's so many questions and concerns, Evelyn, and I'm just thinking maybe we may not conclusively handle everything today, since members here have many questions, many. The chat box is full, the questions are many, and I'm sure many are still on the way. So, in the interest,
I think, hello, Doctor.
Yes.
What you can do, I can share with them my number. They can always send me their questions. I'll still answer them on WhatsApp.
Thank you.
And I'll call each one of them to discuss their issues. So you should not be worried about that.
Thank you very much. So for everyone who has questions, I have also sent in Daktari's number on the chat box. You can always call her. She has committed to answer your calls and to discuss with you. From us as LMSK, I think, Daktari, this demands for a part 2. And maybe we can have a series so that maybe some of these issues can be answered well. So on behalf of all the participants who participated today, I want to say thank you so much, Evelyn, for taking your time to come. We had over 3,000 participants joining. And for those of us who are asking about the notes or this presentation, it's there on our YouTube. It was live, so it will be there. You can still go there and refer and go back and listen to where you didn't understand well. And for those of us who may be having more questions, kindly contact Daktari. She will be able to assist you. Otherwise, at this particular moment, I think we've come to the very end of this presentation. And as I'd said earlier, we were to have a guest from KMHTB, but the presentation has been a bit wide and informative, and members had so many concerns. And from our chat box, we can see there are also so many issues with the regulator, so many individual questions. And we felt also maybe it may not be dealt with conclusively. So allow us at this time to postpone this session with the KMHTB because it's 4:40, and we didn't anticipate we'll stretch to this much. Otherwise, there will be, your certificates will be ready and will be coming to your emails. Ensure you just type in the right email and take a minute to confirm that it's the right email. And then we shall be able to stream in your certificates in that email. Otherwise, on behalf of the Lab Medicine Society of Kenya, we say Asante Sana. We meet in our next webinar. Thank you very much.
Bye-bye.